Let's look at a clinical scenario that I guarantee everyone listening has seen. I mean, probably this week, maybe even this morning.
Oh, yeah, without a doubt.
You have this 65-year-old patient. Let's just call her Mrs. Miller. She has osteoarthritis of the knee.
Mm.
And honestly, she is the dream patient in terms of compliance.
Right, the one who actually listens.
Exactly.
Yeah.
You told her to go to physical therapy, and she actually went. She's done a solid 3-month course. She's doing the cloud sets. She's showing up to her appointments. She's trying to lose a little weight. I mean, she has done everything right.
But she is sitting in your exam room, and she just looks frustrated.
Yeah, she really does. She looks at you and says, Doc, it still hurts. I'm still having trouble getting up from a chair. The symptoms are just persistent. And honestly, as a clinician, it's a really tough moment. You feel like you've played your best card.
The conservative card.
Right, the conservative movement-based card, and it didn't win the hand.
It is the classic clinical plateau.
Yeah.
And it puts you in a very specific bind. You're at this fork in the road. Mrs. Miller is looking at you for the next move. So what is the move? Do you escalate? Do you start layering in pharmacologic agents?
No.
Or do you hold the line, tell her to be patient, and keep focusing solely on the physical therapy?
And the stakes feel surprisingly high there. Because on one hand, we know PT alone hasn't solved the problem yet.
Mm-hmm.
But on the other hand, jumping to medication isn't exactly a free move. You're introducing side effects, potential interactions costs. It feels like a gamble.
It is a gamble. It's this constant tension between safety and relief.
Mm.
We know that many patients don't achieve full symptom resolution with PT alone, but we also really want to avoid over-medicalizing a mechanical issue if we can avoid it.
Yeah.
We don't want to treat a movement problem with chemistry unless we absolutely have to.
So that is our mission for this deep dive today. We are going to dissect this specific window, that 3-month post-PT mark where symptoms are still nagging. We need to figure out the clinical pathway for balancing pain control, functional improvement, and patient safety. When do we add meds? Which meds? And crucially, when do we absolutely not add them?
Right. And to understand that pivot point, we really have to look at the default posture. If you look at the broad clinical landscape for knee OA, the guidelines heavily favor conservative care. We are talking about weight loss targets, exercise, maybe some short-term steroid injections for acute flares.
But those are the broad strokes for a new patient, right?
Yeah.
We're drilling down into the patient who has already done the conservative start.
Exactly.
Mrs. Miller is 3 months in,
Mm-hmm.
and the clinical standard points us toward a very specific rule here. It isn't switch to meds. It's add, don't switch.
That is the crucial distinction. The recommendation is largely to continue the physical therapy while thoughtfully considering the addition of pharmacologic treatment. It's a concurrent strategy where layering therapy is not swapping them out.
I want to push on that for a second, because I think a lot of patients, and frankly some clinicians, might fall into the trap of thinking, well, the PT didn't work. It failed. So let's stop wasting time driving to the clinic and just try the pills instead. Why is that the wrong instinct?
Because it's a logical fallacy to say the PT failed just because the pain persists.
Yeah.
The PT is providing a structural foundation. It's maintaining range of motion. It's keeping the quads engaging to offload the joint. If you stop that, the joint degrades faster.
Right.
The rationale for combination therapy, keeping the PT and adding the meds, is that they tend to provide moderate additional benefit regarding pain and function compared to just PT alone.
So it's synergistic. The whole is greater than the sum of the parts.
In a sense, yes. Think about the mechanism. If a knee is inflamed, if the synovium is angry, the patient creates a pain inhibition loop. Their brain literally won't let them fire the quad muscle effectively because it hurts too much.
Arthrogenic muscle inhibition.
Exactly. So the PT is trying to strengthen a muscle that the brain is actively trying to shut down.
Yeah.
If we introduce a pharmacologic agent, say an NSAID, we might dampen that inflammatory noise just enough. We lower the threshold. Suddenly, Mrs. Miller can actually engage the muscle during her exercises. The medication allows the therapy to work better.
Okay, that makes sense mechanically.
Yeah.
But you used a phrase a moment ago that I really want to flag. Moderate additional benefit. That feels like a very careful choice of words. We aren't promising miracles here, are we?
We absolutely are not. And this is where we have to be honest about the data. When we look at the efficacy of adding something like an NSAID or duloxetine to a PT regimen, the confidence in the improvement is graded as moderate.
So moderate.
Yeah. It's generally seen as superior to monotherapy, but it's not a cure. We aren't taking a pain score from an 8 to a 0.
So if I'm the clinician, I'm thinking, is it worth it? If I'm only getting moderate improvement, why expose the patient to the risks of long-term medication use?
That is the exact right question to ask. But you have to look at what moderate means to a patient with chronic pain. A moderate reduction in pain might be the difference between being able to walk around the grocery store and having to use one of those electric scooters.
Right.
It might be the difference between sleeping through the night or waking up 3 times. In the context of quality of life, moderate is actually quite significant.
Fair point. Functionality matters way more than the number on the pain scale. Now let's get specific. When we say add pharmacologic therapy, what are we actually reaching for? Are we talking about popping ibuprofen like candy, or is there a hierarchy here?
There is definitely a hierarchy, and this is where the guidelines have really shifted in recent years. We used to jump straight to oral NSAIDs. But for a patient like Mrs. Miller, 65 years old, maybe some other health issues, we really should be looking at topical NSAIDs first.
The gels and creams, diclofenac.
Right. Topical NSAIDs have a much friendlier safety profile. You get high concentration in the local tissue, the knee joint itself, but very low systemic absorption. So you minimize the risk to the gut and the kidneys compared to taking oral naproxen or ibuprofen.
So step one in our add don't switch protocol is likely a topical agent. It's the lowest hanging fruit.
It should be. It's the safest bridge. If that doesn't work or if the patient just really prefers a pill, then we look at oral NSAIDs or perhaps duloxetine if there's a neuropathic or central sensitization component. But we start with safety first.
Okay, so that is the default. Keep the PT going, add a pharmacologic agent, preferably a topical one to start. But medicine is rarely one size fits all. There have to be scenarios where we deviate from this. When do we not add the medication?
This is where risk stratification becomes the most important part of the visit. The add medication rule is not a mandate. It's a guideline that requires us to look at the whole patient. There are specific risk profiles where adding an NSAID, even a topical one, but certainly an oral one, creates way more danger than the potential pain relief is worth.
I assume we were talking about the big three here: gut, heart, kidneys.
Precisely. Let's break them down because the mechanisms really matter. Start with the gut. Gastrointestinal issues are a major red flag. If a patient has a history of GI bleeds, peptic ulcers, or even severe GERD, throwing a chronic oral NSAID on top of that is high-risk behavior. You are essentially stripping away the mucosal protection of the stomach lining.
And in an elderly population, a GI bleed is a life-threatening event. It's not just a tummy ache.
Exactly. Then there is heart health. We know that NSAIDs can cause fluid retention. They can destabilize blood pressure control. If Mrs. Miller has congestive heart failure or hypertension that is already difficult to manage, an NSAID can literally tip her over the edge.
And finally, the kidneys. This is the one that I feel gets missed the most often in primary care until the labs come back abnormal.
It is so insidious. In an elderly population, which is our primary demographic for NEOA, subclinical renal insufficiency is incredibly common. Their creatinine might look okay, but their GFR is bordering on stage 3.
Can you explain the mechanics there? Why do NSAIDs hate kidneys so much?
It's all about blood flow. The kidneys rely on prostaglandins to keep the afferent arterioles dilated. That keeps the blood flowing into the filter.
Right.
Well, NSAIDs work by blocking prostaglandins, so effectively you are clamping down on the blood supply to the kidney. If a patient is already dehydrated or has baseline kidney disease, you can precipitate acute kidney injury very quickly.
So what is the clinical takeaway for those patients? If Mrs. Jones has stage 3 kidney disease and a history of ulcers, we aren't adding the meds. That door is closed. What do we do instead?
In those high-risk profiles, the focus must remain on non-drug options. We have to double down on the conservative management. We might intensify the physical therapy, look at different modalities like aquatic therapy, which unloads the joint, or focus heavily on the weight loss component if that hasn't been fully maximized.
Or maybe injections, corticosteroids?
Potentially, yes. An intra-articular steroid injection stays mostly local and avoids those systemic risks to the kidneys and gut. It's a very viable alternative when oral meds are off the table.
There's another factor here that I think gets overlooked in the algorithms, and that is the patient's own voice. Patient preference. We've all had that patient who brings in a gallon bag of medications and says, I am not taking one more pill.
The pill burden, it is a huge issue. Adherence is the silent killer of treatment plans. If Mrs. Miller is already taking a statin, a beta blocker metformin, and a vitamin D supplement, adding a 3 times daily NSAID regimen might just be the straw that breaks the camel's back.
She just won't take it.
Exactly. Or she'll take it sporadically, when she remembers, or only when the pain is really bad, which means she never actually gets the steady state anti-inflammatory benefit. So we are back to square one.
Yeah.
If a patient has a strong philosophical objection to taking daily medication, or they're just overwhelmed, prescribing another drug is often futile. In that case, intensifying the therapy is the appropriate clinical path. Autonomy has to drive the bus.
I want to shift gears to the knee itself. We've talked about the patient's systemic health, their heart, their kidneys, their preferences. But what about the severity of the osteoarthritis? Does the stage of the disease change the decision?
It absolutely does, and this is a critical fork in the road. We have to differentiate between mild to moderate OA and severe OA. The response to treatment is very, very different.
Walk us through that. How do we distinguish them clinically? Are we just looking at the x-ray?
We shouldn't just look at the x-ray. We treat the patient, not the film. But clinically, mild to moderate cases tend to look like the default scenario we discussed earlier. The patient has pain, but they still have some function. They can walk, they can get up from a chair, but it hurts.
Right.
These patients often benefit more from the addition of medications. There is still joint space, there's still manageable inflammation. The meds can bridge the gap.
But then you have the severe cases, the bone-on-bone scenario.
Right. This is the red flag scenario we need to be vigilant for. If you have a patient with severe osteoarthritis who has major functional limitations, I mean, they can't walk a city block, can't climb a flight of stairs, their knee is physically buckling, and they are still symptomatic despite combined treatment or extensive PT, throwing more medication at them is unlikely to move the needle.
Because the problem isn't just inflammation anymore. It's mechanical failure.
Precisely. You have a mechanical block. You have osteophytes grinding against each other. No amount of ibuprofen or duloxetine is going to smooth out a bone spur or regenerate cartilage that just isn't there.
It feels like at that point, if we keep prescribing, we are just stalling.
We are, and that's a disservice to the patient. In these severe cases, the action plan changes. The recommendation is to reassess the diagnosis and seriously consider a referral for surgical evaluation. We should be sending them to an orthopedist for a total knee arthroplasty consult rather than simply cycling through different NSAIDs or increasing dosages.
So it's a triage moment. Mild and moderate gets the add meds approach. Severe functional failure gets the call, the surgeon approach.
Generally, yes. It prevents us from getting stuck in a loop of ineffective conservative care. Prolonging that loop just leads to deconditioning and more misery.
I want to circle back to something we touched on earlier, which is the replacement fallacy. I feel like this is a specific trap clinicians and patients fall into all the time.
It is the most common pitfall. We see it constantly.
It goes like this. I prescribe the medication, and the patient unconsciously thinks, okay, great, I have the medicine now. That's the treatment. And they stop doing the leg lifts. They stop going to the gym.
It's human nature. We want the easy fix. If the pill reduces the pain, why do the hard work? But that is clinically disastrous. The clinical pathway is very strict on this. Starting medication should never be a signal to stop physical therapy. They are concurrent treatments.
I like to use the car analogy for this. The medication is the oil in the engine. It makes things run smoothly. But the physical therapy is the gas. It's the actual movement.
I love that.
Yeah, if you put oil in the car but don't put gas in, you aren't going anywhere. You're just sitting in a well-lubricated driveway.
That is a perfect analogy. The medication facilitates the movement. It doesn't replace it. If you stop the PT, you lose the mechanical strengthening and gait training that is actually protecting the joint. You might feel a little better because of the drugs, but your knee is getting weaker every single day.
So we have to be explicit. We have to tell Mrs. Miller, this pill is only here to help you do your homework. It is not a replacement for your homework.
Exactly.
There's one other pitfall I want to address here. Expectation management. We talked about moderate benefit. How do we frame this conversation so the patient doesn't come back in 4 weeks feeling totally disappointed?
Yeah.
Because we live in a culture that loves a pharmaceutical fix. They want a cure.
We have to be brutally honest about the data, but in a supportive way. We cannot say with certainty that adding meds guarantees substantial benefit. We can't promise it will improve their quality of life significantly.
That's a really tough sell. Here, take this pill. It might help a moderate amount.
But it is the ethical sell. We frame it as, this offers us a chance for moderate additional relief. We explicitly say clinicians should not assume adding meds will resolve pain or fully restore function. If we set the bar at cure, we fail. If we set the bar at turning down the volume so you can live your life, we are aligned with the evidence.
It's about redefining success. Success isn't zero pain. Success is enough relief to go to the grocery store.
Exactly. And frankly, helping a patient accept that goal is often harder than prescribing the medication itself. It requires a real conversation about chronic disease management versus acute injury repair. We aren't fixing a broken bone, we are managing a degenerative condition.
And speaking of evidence, there's a note in the broader clinical consensus about which evidence we use. We need to be careful about where we get our data.
Right. We have to be careful not to apply evidence from early treatment phases to this specific group. These are patients with persistent symptoms after 3 months. That is a completely different biological and psychological cohort than someone with fresh acute knee pain from a twist or a fall.
So data from a study on day 1 knee pain doesn't necessarily apply to the patient at week 12.
Exactly. The inflammatory markers are different, the central sensitization in the brain is different, and along those lines, we need to avoid rigid numeric cutoffs. We shouldn't say, well, your pain score is a 6, so you get meds, but if it were a 5, you wouldn't.
Treat the patient, not the number.
Always. Unvalidated thresholds are dangerous. Clinical judgment is absolutely required. You have to look at the person. Is a pain score of 4 keeping them from playing with their grandkids? Then it matters. Is a pain score of 6 something they ignore because they are tough as nails? Maybe we hold off. Context is king.
It really does come back to the art of medicine, doesn't it? The guidelines give us the map, but we have to drive the car.
The map is useful, but the terrain varies.
So let's try to synthesize this for the clinician listening who has a full schedule tomorrow and will almost certainly see a Mrs. Miller. If we boil this down to a golden rule summary.
The golden rule is this. For adults with knee OA and persistent symptoms after 3 months of PT, the standard of care is to continue PT and add pharmacologic therapy. That is your baseline move.
But, and there is always a but.
The caveat summary. This rule applies unless there are contraindications like GI heart or kidney issues. It applies unless there is a strong patient preference against drugs. And it applies unless the OA is severe enough functionally and structurally that you should be calling a surgeon instead of writing a prescription.
It's a flowchart. Start at add meds and then check your exit ramps for safety and severity.
That is the most concise way to view it. And remember, start with topicals if you can. Safety first.
What I find fascinating here, and maybe this is where we can leave you, the listener, to think, is the nuance of that moderate confidence. We know combining treatments helps. The data absolutely supports it. But because it doesn't guarantee quality of life improvements, it fundamentally changes the texture of the doctor-patient relationship.
It really does. It shifts us from being healers who fix things to partners who manage things.
How does that change the way a clinician frames the conversation? If I can't offer a fix, what am I offering?
You are offering a strategy. You are offering a path through the woods. It might not be a paved highway, but it's better than being stuck in the brush. And for a patient in pain, having a plan, even a moderate one, is incredibly powerful.
That is a critical thought to carry into the clinic. We are offering a strategy, not a magic wand. When a patient sits down expecting a cure from a pill, navigating that shift in expectations might just be the most important intervention of all.